Welcome to the annual general meeting of the Buckinghamshire Healthcare NHS Trust. I think this is a year where we can be quite proud of the improvement trajectory we've been on. Particularly with all the fuss in the media about the Darzi report this week, which does emphasise a lot of the challenges that this trust has faced in common with many other parts of the NHS this year. It is a tough time at the moment. Financial restriction, long waiting list we need to address. So I think we're quite proud of what we've managed to achieve this year, but having said that, that still leaves us an awful long way to go. We set a number of key objectives at the beginning of the year, and largely we've managed to achieve those. And a bit later, Neil will take you through some of the progress we've made against those objectives, but I'm going to steal a bit of his thunder and just highlight we have reduced the number of people on our waiting list, particularly people waiting over 65 weeks, which was a key government target. And that was 782 patients in March 23 and only 13 by the end of March 24, and those 13 were largely patient choice in waiting over 65 weeks. And we've also met the national standard for diagnosing 75% of new cancers within 28 days of referral, and we've halved the number of people waiting over 6 weeks for a scope or scan or hearing test. So we have moved in the right direction, but as I said, that's caveated by saying we've still got a long way to go to provide a service we could be truly proud of. But we're proud of the distance we've travelled this year. And of course you will all know that that was achieved despite several periods of industrial action. And let's hope with the pay settlements that have been made that industrial action is behind us. We've had one piece of industrial action at the beginning of July this year. At the moment, there doesn't seem to be any further industrial action but of course at the moment GPs are potentially taking some action, which at the moment doesn't seem to have impacted us too badly, but that's not resolved, so it may get worse in the future. So we've got a lot to look forward to in the year we're now in. So actually in month 5 of the new year, in fact month 6 of the new year as we're in September. But in April we opened a state-of-the-art interventional suite, which is very important, and work is underway to expand the community diagnostic centre in Amersham with a further new MRI and CT scanners. So again, trying to improve that turnaround in diagnostics is really important. And before winter, I think it's November, is the latest prediction, we will have a new 21-bedded ward open in Stoke Mandeville, which will be used as a medical assessment unit and trying to take medical patients directly there rather than in ED, so that the acute medical take team can practice all in one place rather than be pulled between 2 or 3 settings. And that, I think, will be really important. So it's not just 21, any old 21 beds, it facilitates a new model of operating within the emergency floor. And we are creating a centre of excellence for ophthalmology. We are one of the few trusts, certainly in the Thames Valley Trust, that have a sufficient volume of ophthalmology that allows us to have junior doctors. In some of the other trusts where a large part of it has gone to the private sector, then there isn't always enough work for the junior doctors to train on. So we are a bit of a beacon already in the Thames Valley on ophthalmology. And from the board's point of view, none of this could be achieved without the 6,300 colleagues that work with us, our volunteers and partner organisations. So just to say, express our gratitude to them. And over the summer, we've celebrated the 75th birthday of the NHS, but also slightly more recently, the 80th anniversary of the founding of the National Spinal Injury Centre. the only spinal injury centre in the UK to provide care for children as well as adults. So before I hand over to John Evans, our Chief Finance Officer, we're just going to show you a little video.
We're celebrating the 80th anniversary of the opening, effectively, of the first spinal injury centre in the world, which is now morphed into the National Spinal Injury Centre based here at Stoke Mandeville Hospital. Back when Gutman started the centre, people with spinal injuries were living very short periods of time. They died very quickly from kidney and bladder problems and also respiratory problems. And now many of them can look forward to long and productive lives. He was certainly a pioneer. He had a very strong character, but he set standards of care which hold almost to this day. So in the early stages, it was very much focused on concentrating on bladder injuries, supporting people to use catheterisation appropriately and avoiding some of the consequences of immobilisation such as pressure sores. Really basic stuff that is fundamental to the principles of spinal injury care even today. We've got the only paediatric children's centre in the UK, and we see 25 or so new paediatric patients coming to us each year, and they often come for multiple visits. And there are 150 adults that come each time as well. We've got a massive track record in upper limb rehabilitation, and we're building teams around the centre like plastic surgeons who are interested in hand surgery to support patients to live functioning lives.
I had my spinal stroke back in 2016, and when I first came into the spinal unit, I couldn't use my hands at all. I couldn't do basic things like brushing my teeth or holding a pen. And now look at me. They did a lot of work with me, and I'm trying my best to be independent and having a great life.
Morning, I'm John Evans. I'm the Chief Finance Officer here at Bucks. Good to see you all this morning. So I'm going to give us a run through of our financial performance the last financial year. I'm going to talk a little bit about our financial performance that we're planning for this financial year. We're nearly halfway through. And a little bit about where we've got to in terms of spend on things like our medical equipment in the estate. So it's called capital expenditure. And a brief run through of where we've got to in our in-house charity as well. So if you go to the next slide, please. Quite a lot of detail on here, but what you need to know is that our financial performance last year, we ended with a deficit of just over £5 million, 5.6 million. That was an improvement on the previous year of nearly £10 million, and entirely in line with the financial performance that we had agreed with our oversight bodies, both NHS England and with our partners across the Buckinghamshire, Oxfordshire and Berkshire West integrated care system, of whom we work very, very closely with, and our financial performance impacts on theirs as it all gets added together. We have worked last financial year to a set of financial arrangements, again, which were to incentivise and promote the recovery of elective care. You'll be very familiar as we came out of the pandemic. We have said, as David's described, quite significant waiting lists across the country and for this trust. And the financial regime that was put in place was to incentivise and reward us as an organisation for treating more and more patients. So our patients aren't waiting as long, and so they're receiving the care as they can as quickly as possible. We did very well in that, in terms of we treated more patients than we had planned to. We earned more income as a result than we had planned to, and that helped deliver our financial performance last year. We were quite significantly disrupted in year for two reasons. One, nationally, the impact of industrial action. We lost overall about a month's worth. There was a month's worth of disruption over the year, quite significant. And also we had some quite significant challenges around unavailability of theatres, in particular over the first half of the year. We lost an estimated about 10% of our theatre capacity over the first half of the year, 5% over the whole year. And going back to the being incentivised to treat more patients, that made it quite difficult to earn more money. But even despite those challenges, we earned more than we had planned to, helping us kind of recover and improve upon our financial performance. Our payment for other elements of care, so urgent care, patients coming through our emergency department, non-electives, etc., were and still are funded on a block basis. So we're given a chunk of money in order to deliver all of those services, regardless of the number of patients that we treat. That's been positive in terms of us being able to redesign some of our clinical services and clinical pathways. And again, David's referred to us opening a new ward. So we've had kind of certainty around money coming in so we can move money around to help make those changes where perhaps in the past that hasn't been possible. But it's also led to challenges where we've seen year-on-year increases in patients coming through those pathways around how we balance the resource, our people, and the other money that we spend versus that. And that's going to be a kind of ongoing challenge, I'm sure, as we move forward over the coming years. I've said we delivered what we had committed to do despite those challenges, and I think that is not the case, I'm going to say, nationally. We had some really difficult challenges and decisions, in particular over the second half of the year, around how we would invest in more capacity to treat more patients and help reduce our waiting times, both around elective care and also our diagnostic waits, which I'm sure we'll be referring to, around making quite significant inroads into those areas and bringing people in for diagnostics and understanding those things earlier than we might otherwise be. And Neil will be picking up as part of our overall objectives, but certainly those aligned very closely to the money. All of that has played out around us being able to demonstrate an improvement in our productivity. So we are kind of managed and reported from our colleagues at NHS England around quite a simple calculation, actually. How much money we spend compared to how many patients we treat. And we set ourselves an ambition that we would improve that by 5%. Even with those challenges around lost capacity because of industrial action and lost capacity because of our unavailability of theatres, we got to 4.5%. Right, so I'm going to round up. I'm an accountant, so I'm going to call that 5. So even despite that, we were only, and we hadn't planned for either of those two quite significant disruptions. We still got there or thereabouts. And I think in terms of our story and our message to our wider colleagues and the public, we had a very, very clear plan. And we've delivered those points, and that's meant we've been able to treat patients sooner. That's meant we've been able to get a tighter grip on the money. And the reason that that's important, and I'll talk about it in a second, is us being able to then create some headroom or some spare money to be able to invest in those changes in services that we want to do. Thank you. So, capital expenditure. So, what that means in simple terms is where we spend money on bits of kit, medical equipment in particular, but also our estate. You'll see, or will have seen, certainly over the last kind of year, 18 months, quite a significant amount of work happening here on this site. If you're over at Amersham, you would have seen the same. And we spent last year £58.6 million, so nearly £60 million, and that's one of the largest capital programmes that this organisation has ever seen. About half of that, or a little bit more than half of that money, has come from separate external money. We're given basically a block of money at the beginning of the year, about 20 odd million, to do the kind of as usual things, maintain our estate, refresh our equipment, etc. But we purposefully bidded through competitive processes and won access to money for the rest of that. That requires quite a lot of work. That requires quite a lot of planning. That requires an ability for us as an organisation to articulate quite a clear case on what we need the money for, what risk it's going to manage, and how that's going to deliver benefits to our patients. Those are we compete with organisations regionally or nationally for that. And that has meant that we've been able to bring in investment to the organisation of significant tens of millions of pounds to do the things that have got a little star on the right-hand side. So we've got a second half of this building, the building that you're in now. It's quite good that we're here actually, because I can tell you, if you walk through that little tunnel there, the whole half of that building we were able to invest in to support some of our colleagues coming out of quite old estate that you wouldn't want to work in, to allow us to continue to develop around our research agenda and have some ring fence space to be able to do that, and really give a kind of in one place piece of estate for us to be able to continue to work together more effectively. We continue to invest in our community diagnostic centre, so an MRI and CT scanner at Amersham. We're in the last knockings of that now, and we have had quite significant investment in our digital journey, in particular our electronic patient record that we continue to invest in to digitise the organisation and give access to our frontline colleagues to make better decisions to the care of our patients as we move forward. And of course, David's already referred to the investment in our new ward, the majority of the spend of which we incurred last year. So we spent nearly £60 million. We spent everything that we had said we were going to spend, which is important, so that we didn't underspend or anything. We also didn't overspend from a control point of view. And you can see in the table there kind of broadly how we spent that money. We ended the year with just under £10 million, £7.8 million worth of cash. And I should probably just say, in terms of pre-scene and moving on to the next year, clearly in a deficit position. We're not in a position where we're going to run out of cash and not pay payroll. That's not, there are arrangements within place within the NHS to prevent that from happening. But it does mean our ability to manage payments with our suppliers and other things are tighter than they might otherwise be because of the financial challenges we have as an organisation and the wider NHS does. Can we go to the next slide, please? So, this year, I live my world in financial years. We're now in the 24-25 financial year that started in April this calendar year. Got a really challenging year. I'm not really the type of chief finance officer that says it was all right last year and it's doom and gloom this year. I think we've got an extension of the challenges that we've seen as part of the recovery from the pandemic. Some of those challenges which David's already referred to. We've seen in quite a challenging environment a real terms, so that means kind of inflation adjusted reduction in our income. So we're being paid less this year to provide services than we were last year. That gives us a challenge on how we balance the books. That's led directly into the scale of deficit that we're planning for this year. So a deficit of nearly £23 million. Remember, I said to you last year we delivered a deficit of nearly £6. That's because of those reductions in funding that we feel as a leadership team and as an organisation we're not able to deliver through reducing cost or improving productivity. That is part of an agreed position that we now have with our system partners across the integrated care system and with our colleagues at NHS England. So there's no risk that that's not agreed, in inverted commas. But it does mean that there are knock-on implications for cash, kind of, and other flexibilities that we might have that we continue to work through. Absolutely, there's an expectation, and you'll have seen in the media, around a kind of recovery and improvement in long waiting times. We remain committed to that and have a plan to help support delivery of that. But we're going to need to do so with a reduced workforce. And what I mean for that, just to be really specific, is we've been really fortunate that a number of colleagues, quite a large number of colleagues, have chosen to join our organisation over the last year to 18 months, be it through an internationally educated route, be it through new student nurses coming through locally, or just colleagues choosing to join us from other organisations. And that's meant that the amount of people that come and work for BHT and are substantive, i.e. they have a contract with us and they work as part of that contract day in, day out. Those numbers have increased quite a lot. And what we haven't done or hadn't done towards the back end of last year was reduce the kind of temporary staffing elements that was used as a buffer to make sure we could provide safe and quality care. We hadn't reduced those things in line with our substantive workforce increasing. So we've got some specific programmes in place this year to kind of rebalance those things, to support clearly the delivery of the money, but also make sure that we're in a position kind of sustainably to be able to create some headroom to invest in the services that we want to invest in for the patients of Bucks moving forward. Our capital program this year is a bit smaller than last year. As I said, we received quite a chunk of money last year for big externally funded programs. We still have some of those this year, but the biggest one relates to the continuation of our electronic patient record, and that means we're expecting to spend about £36 million this year. We've got plans to do so. And then finally, as I've said, given the scale of our financial deficit, we've got some challenges around cash. We will be accessing the kind of cash support mechanisms that are in place through NHS England to make sure we can pay the payroll. There are no concerns that we're not going to pay the payroll. I'm going to say that again. All right, can we move on to the next slide, please? So finally, charity accounts. We're incredibly grateful. I, with Nicola Gillam at the back here, our non-executive, work very closely with our charitable funds committee. We had a very, very solid year last year. We're very much grateful to individuals and families and other organisations that have donated funds to us, and those that have left legacies and raised money for us. It's very, very, very important that we use that, certainly as the money becomes tight, but also to allow us and colleagues to spend money on things that we might otherwise not be able to do with NHS money. So it's a really, really valuable source of funding for us, and allows us to do a number of things that we wouldn't otherwise be able to do. We've got a breakdown thereof. We've got successful, kind of raised nearly £2 million, 1.9. We spent nearly £1 million, so we've got £1 million still to spend this year. And our focus of support over last financial year was around some medical equipment, some advanced fetal monitors and some therapy equipment, and also an upgraded, and this is the important bit, the upgraded bit, we've got better quality kit for our surgical laser and plastics. I should probably say, in terms of a shout out, we have significant support from another charity, Scan Appeal. We work very closely with them to align our priorities and objectives. And I want to say thank you to them, and also to the national NHS Charities Together project, which supports our trust charity. Thank you.
Hi, morning everybody. Neil, Chief Executive. Chief Executive's role in an AGM, I think, is laid down in guidance that I have to talk about performance. And performance in the health service is largely wrapped around a narrative about access, so waiting times. I've got a load of slides actually that detail some of that stuff. I don't think I'm going to go through them in that detail. What they will show is that in the majority of ways that people access our care, whether that's in their own home, as a child or as a vulnerable adult, or if it's waiting for a bed in the emergency department, or if it's waiting for a diagnosis of cancer or treatment, or it's waiting for planned care. The work that my colleagues in this organisation have done over the last year has made that materially better. In fact, at a faster rate of improvement that is seen clearly across the national average, and is about the third best in the southeast of England. So there's a really significant amount of work that David alluded to with some numbers that has gone into reducing the length of time that people are waiting for stuff. And clearly in healthcare, people waiting for stuff is really important, because the longer it takes us to get to people, the more complicated the problem is to sort out, and the more poorly the individual is. So a huge achievement to all of that. But context, I think, is important. And David alluded to at the start, you can't ignore a national report that's come out this week with a diagnostic of the health service that says the health service is on life support, it needs to be reformed or die, and it is not providing the level of care that it should be doing. And indeed that's correct for us locally, so we are not providing access of care as good as we were 4 years ago. In fact, as good as we were 10 years ago in terms of that length of time that people wait to do our care. So I guess behind the big numbers that are on these slides, and the thousands of people and the tens of thousands of scans and the 55,000 people on a waiting list and the 110,000 people that come into our ED department, there are human stories behind all of these numbers that are really important to talk about. And so in the context of the report that came out this week, what is the stuff behind these numbers that we should be really proud of? So the report talks about lack of investment of capital into the health service. It's been true here. You can come and look around our buildings and see that we are in need of significant capital investment. But I'm really proud of the work that John alluded to, that the teams have done to secure capital investment in quite a difficult environment. I think a £91 million investment in our digital infrastructure over the next 10 years is a huge achievement. Some of the buildings we've been able to secure. This is not easy for us to navigate and to make the case for this investment. So I'm really proud of the teams that have done that. The report talks about productivity and variations in productivity. That's true here as well. But I'm super proud of the numbers again that John had articulated. I think, and we are currently doing about double the number of people through our operating theatres per month as we were 2 years ago. It's a huge amount of work for colleagues to do that and to be able to manage that demand. And every single person we're able to get through quicker means a better outcome for them. So a huge set of things to be proud of in that space. The report talks about inequalities that exist in the communities that we serve. They are very prevalent in Buckinghamshire. We have got significant differences in people's outcomes. We're doing things as an organisation that we would have never have done. The work we've done to try and introduce new novel drugs to reduce people's cholesterol, to look at 2,000 people in this county who will be sitting in some of the most vulnerable parts of our county, is a huge bit of work that won't come through in these numbers, but will be saving heart attacks, strokes and lives over the next 5 to 10 years, and a hugely important bit of work for us to do. The importance of our role that we play in our community and the value that we add to the community in terms of employment or carbon reduction or pollution. These are hugely important societal goals which come to the heart of what Darcy was talking about, is that the populations have got sicker. And when they come to us, they're more in need and they're more poorly. So the work that we do to try and create ourselves as a valuable anchor in the county of Buckinghamshire through working with schools and giving kids access to employment is hugely important. The report also talks about the impact on the workforce of the NHS and what's happened over the last 4 years. You can't go through a traumatic experience of 2 years like a pandemic and not expect that to have that consequences. And again, I'm really proud that we're able to, as John said, grow our workforce, but also measure it in terms of people's well-being and support and see what they need and how we can make those better, whilst also significantly increasing the diversity of our workforce and the people who look after us. And I guess finally the report says that we've not done enough and we haven't to shift care out of the hospital into our communities in primary care. And I'm really proud of the work that we've done around working now with GPs, working with our community services to really build those neighbourhood teams that will be looking after people in the future, not only in a healthcare setting, but also voluntary care setting. That will mean some difficult decisions that we have to make about whether the hospital can continue to run all its services and what we have to move out into primary and community care. But really important if we are able to tackle the burden of disease that will be coming up. Because in this county, at 2030, which is only about 5.5 years away, the number of people over the age of 85 will be 18% higher. And so the extrapolation of that in terms of disease and demand is pretty extraordinary, that we need to do some work to. So the work that we've done to try and pull together all those different strands, I'm hugely proud of and is a really good, I think, reflection of everything this organisation has done this year.
In Buckinghamshire, our population is increasingly ageing and more people are living with multiple long-term conditions, which is increasing demand. So that means we need to do things differently. To be able to do that, we've been focusing more on supporting more people in the community and increasing our focus on prevention, with a particular focus on start well, live well and age well.
The purpose of the Start Well programme is to ensure that children get the best start in life. We know if we get pregnancy and the early years right, then it reduces health issues throughout the whole lifespan of that individual.
On the 1st of June 2023, we launched our in-house smoking cessation service. Our maternity tobacco dependency advisor sees all women who book their pregnancy at BHT and offers them stop smoking support and quit aids like nicotine replacement therapy, as well as vapes as well. We know that smoking in pregnancy is the leading modifiable risk factor to prevent stillbirth, preterm birth sudden infant death syndrome. So we've still got lots more to do. We still want to reduce the percentage of women that are smoking in pregnancy and at the end of their pregnancy, and also postnatally as well, because we know the harms to the baby as well.
We launched Chat Health about 12 months ago, but since then we've been doing ongoing collaborative work with our children and young people centres, other local services as well, and sort of taking opportunities to promote lots of lunchtime events, going to the schools, doing lots of community events as well, working with our family centres, and alongside the kind of the websites that we've had, Health for Kids, Health for Teens, we've also got a Health for Under 5s website as well now to support the health visitors and really achieve that start well element.
We've launched the Chat Health service, so we'll get teenagers messaging about different things they may be going through. So sometimes it might be anxiety, it might be self-harm, it might be friendship issues. We'll just do a little talk with them, or we may invite them to see one of the school nurses.
We know having a high cholesterol is linked to having further cardiovascular events, so further heart attacks and strokes if you've had one in the past. We've used an innovative population healthcare tool. That tool looks at the shared care record, so that's the information we share between ourselves as the hospital, but also our primary care partners and GP practices. We pool all of that information and we're looking for patients who have got a high cholesterol and a history of cardiovascular disease. For those patients, we call them in, we send them a letter and we explain that we want to talk to them about ways we can reduce their risk of having another cardiovascular event in the future. And in that way, we hope to reduce their chance of having that event by reducing their cholesterol with a range of medications which are approved for use on the NHS.
We're one of the first trusts to adopt an AI system to help fast-track patients with skin cancer for treatment.
Over a decade, the number of referrals that came from primary care into BHC was 300% increased, and that's not sustainable. And the problem is that that's increasing year on year on year. And so we needed to be able to come up with a solution that helped support our dermatology and plastics colleagues, as well as our primary care colleagues, in order to make sure patients are seen as quickly as possible. We're really proud that we were chosen by NHS England as one of only 7 sites through the country to evaluate skin analytics and their Derm AI platform.
When the patients had their referral, they come to see us at the Telederm clinic. We do some specialist dermoscopic imaging, and then we're also able to offer them the opportunity to have the images done using the AI system with skin analytics. We can then directly upload the images straight from the iPhone to the patient's case record. So the AI uses the answers to the patient's questions and the images that we send to make an assessment of the lesion. It will then generate a report that goes to the dermatology team. They are then able to contact the patient and let them know whether they need to come back for any treatment or any surgery, or if the lesion's non-cancerous, they can just be discharged back to their GP, or they can go home and not worry about it.
Our new interventional radiology suite is one of only 2 such radiology suites in the country.
What's really exciting about this is the AI package it comes with. So we're able to do 3D spins at a really low dose, then imports to our machine, and using AI software helps us develop trajectories and identify biopsy sites. It allows us to push the boundaries of interventional radiology. We're able to reduce the dose to patient dramatically. We're developing new procedures, and it's really aided us in giving the best possible experience to patients. And I really feel we're making a difference here with this equipment.
Our new dedicated telepods, these are confidential spaces, they are bespoke built. The really great thing about this is for patients is they don't have to come into the hospital, and it's a nice space to work for a couple of hours as well.
It's not only inside hospitals that we're changing the way healthcare is delivered, but in the community and on the high street too.
We've got people coming in and out, the public coming in and out of here all day long, and it's just, there's just so many opportunities just to say to them, to signpost them to bits of information or to services or to do their blood pressure, ask them to go on the Pump It Up kiosk to find out what their BMI is, find out what their blood pressure is on that. And a particular gentleman came in, and when I told him about the Pump It Up kiosk, he was really interested, and actually his blood pressure was really high. I would really advise you need to actually go to your doctors today if you possibly can. He came past about a month later and said that he'd been to his doctors. The doctor was really concerned about his blood pressure, and he's now under the cardiac team at the hospital.
We're making sure people get the support they need to live independently after illness or later in life, and to age well.
If people have to wait too long after an illness or stay in hospital, or have a noticeable deterioration in their frailty, then the chances of them falling and requiring hospital care greatly increases. As a result of the changes we've made, we are seeing patients at a stage where they are motivated to consider lifestyle changes, and such interventions at the right time can have a positive impact on being able to age well. I really enjoy helping people to improve their strength and balance and make changes to their lifestyle so that they reduce their risk of falls in the future, they feel more confident, they experience a greater quality of life, they're stronger, they're doing things that they thought they wouldn't do again, they're feeling more confident when they're walking out and about, and just generally enjoying their lives rather than living in fear of another fall.
For some people, it can be harder to bounce back from injuries or illness. We know that if people are to stay long in hospital, this can decrease their muscle strength, decompensate, and it will be harder for them to recover. If somebody comes to ED, they are over 65, they will be assessed by ED and then streamlined to the Frailty SDAC team. Once they are here, we are coming every single day in the morning to prioritize those to be going home earlier, for them to be safely managed at home. So we would liaise with the consultant on duty that day in the morning. And if the person is home by afternoon, we can actually go there and see them home on the same day. Being looked after home means patients are more likely to maintain their independence following an illness. The Frailty Hospital Home team review a patient progress regularly over the telephone or by face-to-face visit in their homes until they are ready to be handed over back to their GPs.
Our staff and volunteers continue to provide outstanding care 24 hours a day, 365 days a year. We want to celebrate our BHT family and all who support them and say a massive thank you.
Right, thank you everybody who put that together. Leslie and your team. I'll happily take any questions.
As the Trust are aware, with the letter that we sent, there is a plan for the Trust to outsource the minor injuries and around 30 of the NHS doctors and nurses to a private provider. The willingness to provide the staff and give them away itself is concerning for us. However, it's bigger than us. We believe that the public should be made aware of the plans to outsource the urgent treatment centre, which has been brought aside from A&E or has been a sectioned off part of accident emergency. So as previously emergency nursing staff and medical staff, we are going to be given into a private company as part of the handover. So we would like the opportunity to challenge those plans and consider any flaws it might have and actually have an impact on the decision making, because the decision was made and given to us on the 15th of August. We feel like they're being actioned very quickly and quietly. And also, given the Darcy report and your recent letter yesterday, Neil, that perhaps with the new 10-year plan, that it could possibly be delayed, where we've got a clearer vision of what we're working towards as opposed to working to an old agenda.
Thanks, Judith. I'm going to pass over to Raghav probably to answer that one.
So Raghav Singh, Chief Operating Officer. So thanks for your question, Judith. So you're right that we've made a decision to look to work with another provider around the urgent treatment centres and the out-of-hours service for GPs. So what we're looking to do, and the rationale for doing that, is looking to work with a primary care provider, because we believe that, as Neil said, the future is about the integration of primary care and secondary care. The vast majority of people who come into those urgent treatment centres have primary care presentations, and we're supporting colleagues in primary care in Wickham and Aylesbury who face the biggest demand in doing so. So it wasn't a decision taken lightly, but that's the rationale for doing so. We also believe that the current model, where we are working in partnership with a primary care provider, that's the GP Federation, Fed Bucks, and there's a hybrid model of delivery, doesn't do well for our patients, and could be improved in terms of creating one team with one vision, what we're trying to do, and looks to the future, as you said, with the Darcy review, with what the Secretary of State has said about increasingly moving care into an integrated way with primary care. So that's what we're trying to do with the intention. I know we've had lots of conversations about it, and we'll continue. We're in a sort of live public procurement process, and we'll continue to update colleagues about what we're doing. It wasn't a decision taken lightly, and realise it impacts significantly on the colleagues working there, and we're working with colleagues, with our people team, to try and ensure that there's the minimum possible impact, but recognise that it will be an impact on those colleagues.
Good, thank you. Just to note, obviously, again, we've received your letter, Judith, that's come to the board, and the board will have that conversation later in the month and obviously respond to that. And I think you've had an offer to meet with David as well. Thank you for coming along today. I hope you enjoyed some of the information. The video and all the detail will be loaded onto our website later. Thank you very much. Take care.